Thank you, Fola. I also encourage you while you're listening to our presentation today to use the Q&A for any questions that you have. That way we won't lose your questions in amongst the chat. I also welcome you to use the chat box as well. If you'd like to introduce yourselves, if you have like comments or thoughts, you'll see that the Community of Practice team will share resources and information in the chat, including information about a certificate of attendance. If you need a certificate of attendance, about halfway through, two things will happen. One is we will ask you to complete a quick poll for us that helps us support our funding. So if you could complete the poll for us, and then also one of the team will invite you to click on a link that'll take you to a page where you fill that page out, and they'll send you in your email a certificate of attendance. And again, just encourage you to come to our website so that you can see our many resources on safer supply. We have a few new publications that you'll find there that you also might find really helpful for your work. All right. And with that, let me turn you over to our guests, Dr. Stephanie Glegg and Dr. Nadia Fairbairn. Thank you very much.
Thank you for that introduction. Nadia, did you want to introduce yourself first?
Sure. Hi, everyone. My name is Nadia Fairbairn. I am a clinician scientist at the BC Centre for Substance Use. So I'm also an addiction medicine physician. I work at St. Paul's Hospital in Vancouver and an assistant professor in the Department of Medicine at the University of British Columbia. And I'd like to also start by acknowledging that I'm a white, uninvited settler on the unceded traditional territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And our study team presenting today recognizes that the ongoing criminalization and institutionalization and discrimination against people who use drugs disproportionately harms Indigenous peoples, and that continuous efforts are needed to dismantle colonial systems of oppression. We see our work is connected to these efforts and hope that the research project we'll be discussing today contributes to the creation of substance use care approaches that are safe and respectful and evidence-based. And it's an honor for me to turn this over to Stephanie Glegg, who was a former postdoctoral trainee working with me and now faculty position at UBC as well. So with that, I will hand it off to you, Stephanie.
Thank you, Nadia. So I just wanted to acknowledge the rest of our team that spans the country. Names are up here, and I'll give you a little bit of background about how we came together as we go along. And I'll take this moment also to relay that this work examines early pandemic responses to the increasingly toxic drug supply and the surge in overdose deaths that continued. It also can inform our next steps, even though it's emerged from early research, because it helps to identify what worked well, what challenges existed, and how we can support sustainability and scale up of safer supply for harm reduction. Okay, so we've had a couple of land acknowledgements, and I'll just put out here the logos of the three Indigenous or First Nations that form the Coast Salish peoples land from which this work was led, and we're grateful for their stewardship of these lands since time immemorial. So a bit of a background: we started this work through CRISM. There was a national environmental scan that launched in 2018 looking at injectable opioid agonist treatment, or IO programs, hoping to observe the rapid scale up of those. It has been a little slower than we had hoped, When the pandemic hit and there was risk mitigation guidance in response to COVID-19, we decided to incorporate safer supply and any of that risk mitigation prescribing into the environmental scan to see what was happening. And that is what we're going to present today. So we had 2 reference dates in this scan. March 1st was the one that we typically did for the IOT, but we wanted to see what was happening before the pandemic was declared here in Canada. So that was the March 1st reference date. And then we also gathered data about May 1st to see what was happening in those early months, although our data collection went all the way until January 2021, looking retrospectively. So just a few definitions before we get started. Most of you are probably familiar with this, but the IOT there is an addiction treatment, usually here in Canada, injectable hydromorphone, but in some cases diacetylmorphine. And it's an evidence-based addiction treatment approach. TIOT emerged from the IOT model, where a tablet-based IOT was taken as preferred by clients. So in some cases injected, for example. And then what we're talking about today, I mean, we incorporated all of these different models into the environmental scan. And so you'll see the data from all of them. But the risk mitigation guidance in BC that came out was to support self-isolation to decrease COVID-19 transmission and to decrease overdose risk. And then safe supply, as we know, is defined by CAPIPUD, a legal and regulated supply of drugs with mind and body altering properties that traditionally have been accessible only through the illicit drug market. And we recognize that the work that we were examining is within a medical model, and that there are other models, and you'll hear from our participants about their thoughts about medical and non-medical safer supply. So the purpose of the work was to describe how these programs operate and who they serve, and to document pandemic-driven changes of what providers were doing in response to the pandemic. And we used surveys for those first 2 purposes. And then we used interviews for the next 2, and those were to identify the barriers and facilitators of implementing and operating safer supply, and then to identify strategies that could support implementation, sustainability, and scale up moving forward. And all of this work is from the perspective of providers. So for the survey methods, we recruited participants. We used a scoping web search, grade literature search, primary literature searches. We looked at funding recipients, anyone who was doing work publications in this area. We also went through professional associations and health authorities, guideline committees, research and clinical networks, and peer and advocacy groups to try and reach as many people as we could. We used email and social media to do this, and then encouraged those who knew other colleagues that were involved in safer supply prescribing or services to take part in the survey. And so we gathered that at the 2 time points, as I mentioned, and we looked at things like the location of the services, the characteristics of the programs and the clients that they serve, what they did in response to COVID, and the interviews focused on the barriers, facilitators, and strategies. So this is what we found. In blue, you'll see the sites that were already operating as of March 1st, 2020. And these are the safer supply risk mitigation. In addition to these, there were 19 IOT sites and 3 TIOT sites. And then in yellow, you'll see the new sites that we identified as of May 1st, 60 additional sites. So quite a rapid increase, with most of it concentrated in BC. We know that these aren't all of the safer supply prescribers that are out there or that were out there at that time, and you'll get a sense of why. Perhaps you've already discussed it, but it's part of our data set, so I'll share that as well. So there were 21 safer supply sites initially, and then an additional 60. And this was across 103 sites in 6 provinces, and we had 50 participants take part. So some were involved at more than one site. Here's just another visual snapshot to show the rapid increase in BC and some growth in some other areas. Where was safer supply being provided? So we had a bunch of substance use specific sites. So dedicated safer supply clinics, some were embedded in opioid agonist treatment, IOT or TIOT clinics, overdose prevention sites and supervised consumption sites, and there were some outreach services. We also saw it in other types of healthcare settings like physicians' private practices, hospitals, community centers, mental health care, and in community, in housing, hospices, shelters, encampments, and not-for-profits and home delivery, especially as the pandemic hit. Many of the sites provided daily witnessed dispensing, and there was a shift in some of that to daily carries or longer term carries with the pandemic. Particularly in sites where there had already been witnessed carries, but some provided, witnessed dosing, but some already provided carries. And it happened on site at a pharmacy, in some cases delivery, especially for COVID. And then there was even a vending machine model. And we saw quite a range of services from prescriber only at a physician's clinic to a site with wraparound care and an interprofessional team, some of whom had people with lived or living experience as workers in those sites. And we saw pharmacies through the health authority at hospitals, for example, embedded in the clinics to partnered with certain pharmacies in the community, or giving clients the choice of which pharmacy they went to go to. For funding, you'll see 4 different categories here. It's important to note that 79% of the sites had no funding for their safer supply services. So they were just taking this on top of the other services that were provided, or that they offered to clients. For those who are interested in what types of substances were available, here's a snapshot. All of the sites offered opioids. For the IOT services, all provided hydromorphone and 2 provided diacetylmorphine. And for TIOT, they were all hydromorphone tablets. And then we spanned a whole range of substances to see what was going on. So if you're interested in some of these other types, feel free to reach out and we can chat further about those details. This is just quickly to show you what happened in response to COVID and how operations changed, what kind of changes were made. And we have a manuscript on this that I have a QR code at the end that I can share. It was in the Harm Reduction Journal, specifically about these changes. So some of the patient protocols that changed were things like reduced urine drugs test frequency, switching to take-home dosing, shorter titration schedules, transitioning to oral opioid agonist treatment. Some of the program operation changes were things like reducing new client intakes, using telehealth more, using personal protective equipment for staff, increasing or even decreasing outreach depending on how things are going. So you can learn more about some of those changes in that other article. I'm going to spend the bulk of the time talking about what we found in the interviews. So we used the Consolidated Framework for Implementation Research, or the CFIR, to guide this work. You don't have to know the framework, but I'll walk you through it as we go. So we coded the transcripts of the interviews according to the constructs in the framework. We mapped the barriers and facilitators to different strategies that participants identified as being helpful for implementation or operational success. And then we use thematic analysis within those construct categories. And so I'll present some of those themes. So there's 5 domains in the CFIR. The first is characteristics of the intervention itself. So what is it about safer supply that was enabling or restricting in terms of using and implementing it? The outer setting refers to things like the policies that exist, funding, supports, the public sentiments, all of that. Inner setting relates to the organization where the services are provided. Individual factors relate to the providers themselves. And then the implementation process looks at, as we're implementing safer supply, at each step along the way, what was a barrier, what enabled us to do this, and how can we suggest strategies. So I can't go over the entire data set, but I'm going to try and squeeze in as much as I can here for you. This is what it looked like when we were mapping things out. So the five domains, they each had their constructs, and then we had barriers with the themes that emerged from those, and with mitigating strategies. And you'll see that some strategies targeted more than one barrier, and some barriers could be targeted by more than one strategy. So those are going to be outlined in forthcoming manuscripts. So we'll start with the intervention specific factors. These are the different constructs in the CFIR, and I'm going to speak to the red ones in a bit more depth, but just for now, in the gray, cost related to, in particular, the domestic supply of diacetylmorphine, which was not available, which was a barrier, and that many provincial plans didn't cover the substances that were being provided or that clients needed provided to them. And for guidelines, it related to feedback about the lack of diversity in the communities, so that they weren't representing all of the people involved to an adequate degree, and that the client perspective was less valued than the research. We'll get to that in another category as well. So the evidence itself, this is one area where participants identified that there was a lack of or conflicting evidence. This is especially early in the pandemic. We're seeing more and more come out. So the strategies that were identified were obviously to conduct diverse research, to do program evaluation of safer supply services, to seek client feedback about their perspectives, and to develop a community of practice, which I'm very pleased to be presenting to you today. Changing evidence was another issue, and so participants wanted ongoing training across the country so that they could learn as new evidence emerged what was going on. You can use all this, Rebecca, for your pitch to get more funding for the COP. And then I mentioned that research was overvalued, and so the providers wanted the lived experience of people accessing safer supply to be valued in the guidelines and other work. Here's a quote around the lack of evidence. Well, to be very blunt, there's absolutely no research to show that this is going to lead to safer outcomes for society as a whole. I mean, you can figure out that there may be some individual benefits to this, but there's no research. I mean, I'm 57 years old. I was from the generation of doctors who, got our wrists slapped for, well, more than that, our licenses threatened for exactly this kind of prescribing 10 years ago, right? And, you need to look at history. You need to look at the research that says there's a lot of harm to unabated opiate prescriptions. And that is very good research, well established. So that's one example. The next construct was relative advantage. And so providers found struggles in balancing the risk with the benefits. And some of the strategies that were identified were acknowledging those benefits of safer supply, bringing those to the forefront, and then looking at risk mitigation. So could dosing happen at safe consumption sites or overdose prevention sites, or be witnessed, for example? So some of the ideas that were emerging. So a quote that said, I'm a little pessimistic on how much good this is doing, as far as decreasing fentanyl use. even on maximum hydromorphone, 16 tabs a day, I feel like people are maybe cutting it in half what they're using, but nobody's abstaining. So yeah, I have a bit of distress some days wondering what the good of this is. But then there was another quote here. The question was, how important would you say in your experience safer supply is for your clients? And the respondent said, it depends on the client, like outrageously important, like it's everything. I think it's life and death. I think it's also how we show respect and support. I think it's a gateway, not to drugs, but it's a gateway to care and to human love and compassion. And I think that is the barrier that causes a lot of people to become despaired and isolate from healthcare. Another factor was the complexity. So complexity of dosing. People wanted a regional algorithm because of the different makeup of the unregulated drug supply in their areas that looked quite different in rural, remote, across the country. And they needed to use their best clinical judgment when making decisions. Also, the factor of concurrent conditions, so whether it was concurrent stimulant use, cognitive impairment, mental health conditions, that this made prescribing more complex for providers. And so they relied on ethics consults, supports for clients. They wanted more mental health supports and inclusive housing to support clients. They found that a strong client relationship helped them work together to figure out what the best approach was for that individual. And they wanted to see clinical measures to help guide their decision making. There were also ethical and legal issues. And so here's a quote for you. Or especially with people who you give stimulants safe for supply, who may be going in and out of psychosis, and my drug could be causing that, but probably not on its own because of all the other things they're mixing with it. And then knowing that when they hit the psychiatry hospital, the first thing they're going to do is say they're being prescribed dexedrine and that's the problem, and to stop it. So it's a lot of systems issues. And because without evidence and background to fall back on, it's a lot more risky medical legally. And also just with the patients, when you don't have that wealth of experience and data to look at, it's my best decisions. But that's kind of where we are. So providers are asking for more training, refined guidance to help them work through these challenges, and found that ethics consults were really helpful for specific case studies. There's another quote around when a person's capacity is changing from day to day, like one day they clearly have capacity and they're making a decision and the other day they don't. That just highlights the some of the complexity that providers faced. So we're going to shift to external factors now. And there were 4 different categories here, and I'll work through them one by one. So social pressure. This was an external factor that many providers felt. And one of the themes that came up was disapproval of colleagues. So they felt that their colleagues didn't believe that it was a good thing to do or that it was safe, and that they discouraged others from prescribing. And what people did in response to this was perhaps prescribe quietly so that they weren't drawing attention to themselves. But in the end, they found that the pandemic tension for change was just too strong, that the risk to people was high and that they needed to do something. I'm in a very conservative and resistant area and atmosphere when it comes to practice for addictions. I got hate emails from the different addiction medicine providers in my region about my practice and what I was prescribing and all of these kinds of things. I had letters of formal complaint and all kinds of issues from them. So that highlights one person's experience. Another external factor was trying to meet clients' needs and the resources that were available. And so people spoke about social determinants of health and how those needed to be addressed in order to be able to meet the client's needs. So they were seeking more housing with supports. In the case of IOT, they made agreements with a housing place to housing organization to provide eye out in the housing, so that clients would need to go elsewhere. And then looked at things like travel vouchers to get people to the clinics so that they could see the providers. Service gaps were pervasive, including low client capacity. So most of the services that we spoke with didn't had large wait lists or stopped taking wait lists because they had just too many people that couldn't provide more services. And so some of the solutions to this would be increasing funding, prioritizing risks or needs, to try and see the most at-risk people in a situation of low capacity, to provide unsupervised or unwitnessed dosing to decrease the demand on providers, and maybe providing phone cards so that they could see patients over the phone. And then they found a mismatch of safer supply with the client's needs. So in some cases, a harm reduction approach wasn't in place. If it was a place that was focused on addiction treatment and their mandate was to get people onto OAT, they needed to look at shifting that to meet the needs of the clients that were coming to access safer supply in some cases. Again, coming into the clinic many times a day, or even accessing people, the hours that were provided didn't match with the client needs. So those are all things that they wanted to see changed. Having a pharmacy on site was really helpful in some cases because they worked with pharmacists who were familiar with the prescribing approaches and didn't need education when they were speaking to them on the phone. And then developing trust and using a client-centered approach were also found to be really helpful. And then the last piece here was discontinuity of care. And so if someone left the safer supply service and went somewhere else, for example, an acute care admission, there wasn't a communication plan in place. They maybe didn't have an electronic medical record, so it was hard to get that information back and forth so that they wouldn't discontinue the stimulant or whatever the case may be. I think we'll skip quotes on that for time. Network connections was the last one. And so people had challenges reaching out to others, especially with the early pandemic. Lots of services were closed or people were working from home and couldn't be reached. And some physicians found that they were isolated in prescribing. So preemptive communication, where you reach out and establish those connections ahead of time, were one strategy, and having just a community practice again, somewhere to connect with others about what the challenges are that you're facing in your practice, to talk about challenging cases, to talk about ethics, all of those things. So yeah, the tension of do this, but don't do that. So that was just very, I don't know, I just felt really alone in that. And so my team is kind of supporting, but this is mainly my program. So I just felt really, really alone. This is one provider that was the only prescriber in the service. And the last area of external factors was policies. So there was a lack of support from authorities. We heard from many providers about fear. We'll talk about that later, but fear of retribution from authorities like the professional college or even from their government. And so they wanted public endorsement and transparency from those entities to say safer supply is something that we support as a harm reduction approach. They thought engaging with the college in some smaller provinces, this was a strategy that had worked well, and having strength in numbers. So you weren't the only person doing this, that there were many of you, and therefore there was a better sense of protection from these consequences. And a lot of providers talked about how the medical model was a poor fit. So they wanted to be practicing in a context where a harm reduction model was appreciated and valued. And many called for decriminalization and legalization of safer supply to get it out of the medical model. So here is a quote. Actually, there. I'll wait on that one. There was confusion about online policies and practice standards. There might not have been guidance in some provinces. And so they wanted more education, more communication, and having these practice standards published. And that policy conflicts with practice or with the client needs. So they weren't able to provide the medications that they wanted to, that they had to advocate for funding or coverage, that they had to provide education, and it was needed for policymakers and in some cases pharmacists. So here's a quote: "Truly, the whole system needs to be demedicalized, and that's not happening within our current framework. It has to be federally, of course, but just being a medicalized model is so problematic in so many ways. There's such a power imbalance between physicians and patients, physicians and nurses, and then nurses and patients. And it's just, this entire program needs to be peer-led so that it's not us making decisions for people who use drugs when we don't really know these things. This really needs to be peer-led." How are we doing for time? How much time have we got left?
It's good. Yeah, you're okay. Go ahead.
Okay. So organizational factors, we'll touch on some of these in the next slides. So these are internal to the organization. So size of the organization was one thing that came up, especially if there was just one prescriber. It made it a lot more challenging to cover off caseloads. And there was a hard time recruiting prescribers because of these fears that were prevalent and the peer pressure. And so prescriber recruitment was one of the key strategies that they talked about, and resource allocation to these smaller services so that they could support the needs of their communities. The service delivery model in some cases was a barrier. In some cases, we heard from providers that they didn't have a consistent provider for each client. They would have rotating prescribers, and that was challenging in terms of continuity of care. And if the prescribers had different perspectives about safer supply, that could present challenges. For those that had a dedicated addiction team to support, they found that helpful from the extra expertise and to cover off certain aspects of care. And then there were lots of promising statements about embedding safer supply in housing settings. I've done it in the setting of rotating providers with the drop-in patient scenario, and I've always done it in the setting of attached patients known to the provider. By far, I think for the benefit of the patient and for the comfort of the provider and for tracking of progress, it is way better for a patient to be attached. So I think it works reasonably in an attached patient setting. We also, I'm just remembering a quote of someone who couldn't go on vacation, or when she did, there's nobody to cover her caseload because she couldn't find anyone in her region that was willing to provide safer supply. Organizational culture also presented some barriers. So a punitive approach to care was identified in some settings. And so they advocated for respect and care for the patient, so that it was supporting their needs. A quote here about punitive care was, like a lot of people still feel that it's okay to have punitive responses to dirty urines, which is, we aren't interested in having that relationship with people. So it's interesting to watch people rethink what is possible with care. This is in response to not being able to conduct the urine drug screening. as much, and then really getting to the heart of what is the purpose of this, and is it serving a function. The client de-education was about helping clients re-envision what was possible, so they weren't used to a safer supply prescription, and just learning about what options existed and how that it could meet their needs more effectively. COVID changed the internal culture. We didn't have any strategies that came up for this one, but it was around not being able to do in-person things, like, provide food or have toys out that families could bring their kids when they had to come have witness dosing. They didn't have those options. There was no collective sense of community happening in the clinic anymore, because people would just come in for their scheduled appointment or be seen virtually, and they lost that the culture of belonging that they felt they had before. Here, there's sort of a de-education that needs to happen. People have had so much access to traditionally really punitive structures in addictions care that getting people to expand their imagination and their ideas of what's possible in a relationship with somebody who's helping them with their addictions and their substance use is a big part of it. Implementation climate. So this is just the context where you're implementing safer supply. And the big barrier theme was limited access to resources. So I mentioned that most services didn't have dedicated funding. They did it off the sides of their desks or repurposed what they had. So funding was identified as being really helpful, more staff recruitment and training for those staff to deliver safer supply in a client-centered way, embedding ancillary services, so that kind of wraparound care or other kind of healthcare or social services on site, or partnering with other services that provide those aspects of care that they don't have the resources to provide. Doing it in a complete vacuum of other services, that's a huge barrier. The fact that people are not housed and getting temporary sheltering, if they're a person of interest, COVID is really a challenge. Getting enough people who believe that this is the right thing to do to be a part of our team. We're going to move on to individual factors now. So this is about the providers themselves, and these are the key areas that came up. And I only have time to go through a couple of them, but one quote here was, "The push for me to get into prescribing safe supply really did come from my patients and having in detail discussions with them about what it would mean for them to have access to that." So being open to that knowledge and wisdom that comes from the patient experience, I think, has been important. So providers talked about having a lack of knowledge about how to prescribe safe supply. So they were asking for community of practice, mentoring support, education and training, and more research to help them make decisions. Some didn't feel they needed this knowledge because it wasn't part of their role, or they didn't see it as part of their role, and thought that it should be looked after by other types of prescribers instead. And as I mentioned before, the pandemic tension for change did shift some thinking. Some saw safe supply as harmful. And so in this sense, it was about identifying the benefits, demonstrating through data that shows that it's effective or helpful for certain outcomes, and highlighting those outcomes. Like anything in medicine, if you don't do it a lot, you don't necessarily want to start getting into prescribing something that you're not as familiar with. So it's just hard to take that jump, and it takes an investment of time. Self-efficacy. So this is around confidence. So providers said they had a lack of comfort with prescribing unless they were already quite experienced. Some used resources like the 24-hour call line that we have here in BC, ethics consults, or consults with an addiction team. They talked about orientation and training for new staff that they provided, as well as going to conferences, working with a mentor, having a community of practice, and establishing that relationship with the client so that they can help guide the plan. And then having detailed clinical guidelines that would help them further make decisions. I think the biggest challenge, and it seems to be the biggest challenge of everyone I've talked to who's doing pandemic prescribing, is about the ethical issues and how to do it right. So how to do it safely and how to do it within the current legal context. You can see some of these themes overlap. This one is sort of buried in the middle of the presentation, but it was actually the theme that came out most prominently, especially for individual factors that prescribers were fearful that they might lose their licenses or have their clinics shut down. And so again, some of these ideas around mentoring or having an influential ally who maybe is more prominent and appreciated, that helped them to have more confidence in prescribing and less fear of retribution if they signed off on a script, for example. Having flexible guidelines that would help them meet the needs of the different clients rather than something rigid that might not. More training and having more safe supply prescribers so that there was a collective instead of just feeling isolated. So this government official has actually told the executive director of my clinic that my clinic is red flagged because they know safe supply prescribing is going on at the clinic, which, like, what does that even mean? Yeah, it's not a government that is above bullying and targeting. So there's very much a fear that if we formally advertise that we do safer supply and patients come to us and we formally make a program, that they will target us and suspend our program. Anxiety and hesitancy. So this, is partnered with the fear, but also just anxiety around making good clinical decisions. This was countered by clients asking for safer supply. The provider confirming that other options aren't working, reviewing cases with a medical lead, or again, using some sort of consult call line that would help with decision making. And resentment. This one was around again this pressure from outside, and feeling like they don't have the supports that they need. So having education and training for safer supply would help to mitigate that. The last category, last domain, is the implementation process itself. So in the framework, it's split into 4 categories: from planning, engaging the people you need to in order to implement, then actually executing the plan to implement safe supply, and then reflecting and evaluating on what you have done. So in the planning stages, very common, we have no experience implementing safer supply. Where do we start? Using publishing clinical and operational guidance for safer supply was one thing that people wanted, as has been done in other types of approaches or treatments. Visiting other programs, or accessing existing policies or protocols. So others have already set things up, and it's really helpful to learn from them who have already been here before. I used their documents that they circulated around safer supply programs to help me think of the things that needed to be in place and to get going. And I think having them being the trailblazers helped to give me a bit of cover and confidence to be able to take steps to do it. In the engaging stage, I already talked about prescribers being hesitant to get on board. And this quote that's coming up is around engaging nurse practitioners as perhaps an option to increase access for clients, as well as mentoring or having opinion leaders that have good standing speaking about it. So I think this runs directly against a lot of the current advice being given to physicians. I think that's why you're going to see nurse practitioners adopting this faster than physicians will. We don't have the same history and baggage, I think, that medicine comes with from the sort of the bad old days of awful prescribing practices. I think it sort of polluted them against the notion of prescribing in these quantities. And of course, we saw a range of quotes. This is just one example. The actual executing of implementation, one of the barriers was just managing change, whether it was of providers or management. And so they talked about needing to set aside resources and time to actually adapt. Very difficult when you're trying to manage a pandemic that's just emerging with so many uncertainties and unknowns, but in the long-term planning to set aside that could be of strong benefit. Fostering a learning climate within the organization, and legal action. Sure what that one is. I don't have a quote for that one specifically, but it might have been around coming to governments to address the steps they were taking to try and prevent safer supply. I think the main barrier to having a safe supply site at our site is the leadership structure, that we're mixed with the mental health, and it's mostly mental health, and it's mostly doctors for the substance use. So there's very little of the medical addiction as part of the addiction and mental health team. So there's no real structure for us to improve and innovate in our program. They talked about how all of the resources and attention to change and innovation was happening in the mental health side of it. And so the addiction and substance use piece they didn't have capacity to move forward with that. So that kind of rounds it up. I just wanted to end with a couple of other slides. One was just summarizing providers' desire for a safe supply that was outside the medical model, with the key actions needing to be taken being decriminalizing and legalizing safer supply or safe supply, removing the prescriber as the gatekeeper, exploring non-healthcare settings for safe supply, and engaging people with lived and living experience throughout the process. But within a medical model, the key things that came out were things like adjusting policies and regulations at the federal and provincial levels, increasing funding, addressing stigma with decision makers, but also providers, conducting research and evaluation, supporting and bringing providers together, addressing the social determinants of health as a priority, partnering with people with lived and living experience, tailoring guidelines to different regions and situations, and then really focusing on providing education and training for those that are taking on safer supply prescribing. This is just a summary of all the key recommendations that I'll just pop up on the slide for you. That brings me to the end of the content. On the next slide, I've got QR codes for the two articles that have been published, that if you want to capture those, I think they're already in the chat though. Thank you, Robin, or whoever did that. And we will move on to questions next.
Great. Thanks so much, Stephanie. Just before we have questions, Follow, can you launch a poll for us? If everybody could take a couple minutes to just fill out this poll, it should take seconds, actually. That's really, really helpful for us for our reporting. But we can continue on. If people have questions for Stephanie or Nadia, who's also on the call, you can put them in the Q&A box there and we'll be able to address those. And some are We'll see. Then I love that you have the QR codes. That's great. Thanks, Stephanie. And they are also in our database, resource database on our website.
I figured they would be.
Any questions? It's a quiet group today.
Ask us anything.
Careful what you say, Stephanie.
I know.
Somebody's raised their hand there.
Oh,
Yeah.
okay. I don't know how to deal with that. Let me just see. Can you put your question in the chat box, Melissa?
Hang on, I think I can click allow to talk and that might work.
Oh, there, it just came up for me.
There.
Oh. Okay, Melissa?
Hello? Hello?
Hi. You have a
Hi.
question?
We don't really have a question per se. I'm just wondering what, I guess, I'm a community worker at Somerset West Community Health Center here in Ottawa. And Safe Supply is one of my programs that I work in the center. I am the only community worker officially working there right now. I was the first and I am the only, and the program is slowly but surely being formed as I work in it. They're now looking at hiring more people and they're shaping the structure of the program and the actual expectations of what my role means. I'm just wondering if you can give me an example of, say, your experience with community workers working in Safe Supply and how far their privileges reach.
I can't answer that. Maybe Nadia can, but I will tell you that in our interviews, we interviewed a whole range of different providers. So some were prescribers and some were peer support workers and some were clinic managers and whatnot. And so depending on Nadia's answer, I might suggest that you reach out to other Safe Supply services and talk to people that are in similar roles or talk to the clinic managers, because they will have a good sense of what's been working well for them, you know, rather than try to recreate the wheel and go in blind. You have you know, a number of people across the country that have been doing this for a couple of years, if not longer, because we had lots of pre-pandemic sites.
Yeah, I can speak to the clinical setting where I work. And this is something that has evolved since this original scan was done, which I really wanted to emphasize was done like right at the beginning of the pandemic, like when everybody was in shock. Personally, services, some of them were temporarily shut down completely. It was a very turbulent time for everyone personally, but also in the healthcare setting. So some of the barriers that were identified have been to some degree addressed just as we've worked out and gotten acclimatized to this COVID context and, you know, safe supply prescribing, et cetera. But we didn't have this initially, but we do now, where at our clinic, we always have a person with lived experience or living experience who works at the kind of greeting area and sits with clients who are waiting to go into the clinic and get triaged there. And they generally have an informal conversation, but the concept of safe supply is often brought up in those conversations. And something that we really faced early on, and we maybe face slightly less today, but still, is even around like what it is. So like if I ever asked anyone like, have you heard of risk mitigation prescribing? People are like, no, like that's a very complicated word and I don't know what you're talking about. And so even safe supply to some degree, we have to kind of spend some time with clients, especially clients new to our clinical space, or maybe who haven't engaged in clinical care in a long time or previously at all, around what is it? What does it kind of look like in the medical model and as part of our clinic? And generally speaking, that person with lived experience working with us will get a sense of whether that may be of interest to the client and whether that may be a fit for them. And then they will communicate that to the prescriber or the nurse seeing them next, often before the clinical assessment happens, saying, I chatted with so-and-so, they're new to the clinic. I mentioned safe supply. That seems like something they'd be interested in. They're certainly at risk for overdose, et cetera, et cetera. Maybe you can bring that up or consider that as part of your assessment. So that's just an example from my own clinical context, but I would say generally, like, having people with lived experience or community folks engaged in the clinic model, I think, can bring safe supply more to the forefront in terms of assessments around an offering of it, and can help kind of unify potentially prescribers who have, as we've identified, maybe fears or concerns or reluctance based on many reasons that we've outlined today that they bring to the table. So just a few ideas. And then I would agree with Stephanie to feel free to reach out, through any of the networks, through this community of practice where there are embedded folks working within clinical contexts to brainstorm further.
Thanks, Nadia and Stephanie. I'll just jump in there and say we do have a program operations meeting on a weekly basis where we talk about things like that, like what roles people can play, what sort of mapping out roles and tasks and responsibilities and things like that for all, like for nurses, for people who are in like service navigation roles, people with lived experience. And we're finding more and more teams that are made up almost completely of people with lived experience as well, which is great. There's another question here for you in the Q&A. Do you want me to read that out, Stephanie, or do you want to just tackle it?
Saw some in the webinar chat too, so I thought I'll just address the chat ones first,
Okay.
and then I'll jump to that one. So around, can you speak about participants' demographics, differences, female, male, rural, urban, recent, long-term prescribers, type of health practitioners, and which barriers can be more specific to certain categories? And then the next one was also, did you find any meaningful differences in barriers, facilitators, strategies, dependent on how long the providers have been working in the substance use field? So yeah, those that had been prescribing longer were less anxious, might have more confidence in their prescribing. Those with access to provincial guidance also felt somewhat more comfortable. In terms of rural and remote, some of the barriers that I talked about in terms of not having coverage, not having others that supported safer supply, practicing around them, or in particular wanting more education because there were less opportunities for them. In general, those came to the forefront there. We also saw quite a difference by province, depending on the political climate. So more fear of clinics being shut down in certain provinces, whereas in others it was more accepted by the government in power. Yeah, those are some of the key ones. And I think, that quote that I shared about the nurse practitioner, from a nurse practitioner saying, maybe we're the place to go. There was, I remember one quote from a physician about the opposite sentiment, because of the lack of having been through the history of the action around opiate overprescribing. And so, there are mixed thoughts around that. And it's not something that I validated since then in terms of our more nurse practitioners doing this, because we haven't repeated our scan. We may have more of a sense in the community practice. Those are thoughts. Nadia, did you want to add anything to that?
Yeah, I would just add that I think there's a contingent of physicians who really do draw this back to the messaging they have received around opioid prescribing as the cause of the overdose crisis in the first place. And what I would consider to be very black and white messaging from regulatory bodies around that, and clear messaging around deprescribing. And I'm sure it's come up in these meetings and elsewhere about the unintended harms that patients have faced from rapid deprescribing following that kind of abrupt change in messaging that, it's the prescriptions that were the cause of all those issues. And I think a lot of nuance and support is needed for prescribers. Oh, just one sec. Around to prescribers around this is different. We're talking about a different context. We're talking about a context where we're dealing with an unregulated drug supply. This is not extrapolatable circumstances necessarily from opioid prescribing problems historically. But I would say that was a particular issue with physicians who trained when pain was the fifth vital sign, for prescribing what they felt was responsibly for pain and other indications, then received clear messaging that was harmful and to stop completely. And all of that messaging and that history, I do think added additional barriers for that kind of cohort of physicians to recontextualize, understand what's going on now, the differences in this current context, et cetera. And so potentially nurse practitioners may not have that same that same historical experience as well, coming from a different training pathway than happened with that cohort of physicians.
And Nadia, you might be well positioned to answer this Q&A. So through your ongoing connections to prescribers in the field, are the key messages regarding barriers and challenges still the main ones you're hearing about today? What, if anything, has changed since your data collection period?
Oh, well, that's a big question. I mean, I defer also to others attending if they wish to chime in, but I do think it's a lot of similar barriers still. I think one of the issues that I would highlight that persists is we really need to help bring clinicians together so they are confident in what they're doing, and they have a place to ask questions and to debrief and to get really specific clinical advice. And still today, I would say there's still a strong sense that there have been some improvements. Like I think this community of practice is a perfect example. And there are other local communities of practice, like we have some, in BC, et cetera, to support folks. But the clinical guidance is not really in depth. So one key example I would provide is there's not really anything guiding clinicians around whether they should be concerned about the issue of diversion or not. When they're prescribing, there's really nothing about it. And it comes up in so many forums around, well, what about diversion and how does that factor in terms of potential harm, benefits, et cetera. And it's a really complex issue. For me, prescribing, most instances of what we would traditionally call diversion is probably people lending to their friends who are in withdrawal, who are at similar risk. And so I think really getting into the important clinical pieces or clinical considerations that are highly relevant to prescribers, and infusing that into clinical guidelines, but also providing forums where that depth of conversation can happen to really overcome those barriers. I think there's still so much work that needs to be done on that front. And again, we're speaking just to the medicalized model. And I think we don't want to underemphasize that what we did hear loud and clear, and we are still hearing loud and clear from prescribers, is they actually do not think it's appropriate to be the folks handling all safer supply for the country, and that it's not possible. It can't be scaled up fully. It can't meet the needs of all clients because it's a medicalized model, and that we definitely need to support prescribers within the medicalized model, and there is a role there. But we really heard clearly, and we're still hearing that is not adequate to properly, truly address a safer supply for folks in Canada.
And some of the barriers that require large scale change are in place still. So There have been some changes to policy and discussions of changes to policy at the federal level. We've seen changes in certain jurisdictions, whether it's towards supporting safe supply or not supporting safe supply in different regions. And so those discrepancies still exist. And when you look at things like supporting network connections among prescribers and other providers, different sectors of the health and social support systems, those take time to deliberately establish. And there's not a lot of time off the side of one's desk to do that, and not an overarching body who has taken that on. So some of those gaps still exist, will continue to exist, and it's, chipping away at some of these issues. And even looking at, housing, we heard many providers talk about how important housing was to support folks that were accessing safer supply for their health, mental health, any kind of outcomes, their participation in society. And, that's a very slow moving piece that, those barriers still exist. So, using this framework that exploded all of the barriers into all these different constructs is helpful in a way, because it shows us that, we're making some gains in the area of connecting providers with one another. There might be some advances or reframing of guidance along the way, but then there are some overarching things that need more support put into place. And, it's the same way for the toxic death crisis that we're experiencing, that there's some easier quick fixes, but they don't address all of the issues that are going on, and it needs a concerted effort, people working together and advocating and putting resources in so that those things can be addressed.
You articulated that so well, because one of the things I think about often is that we've got this emergency, this crisis, and one of the key solutions or approaches to addressing the crisis that Health Canada has stood behind is a medical model of safe supply. And yet to really implement that requires such a cultural shift amongst within the medical community, both in terms of how to work with people who use drugs, as well as how to prescribe opioids. And then all these other policy issues and everything and so these things all, like the way to implement this intervention has all of these pieces to it that are so unbelievably slow moving. So, and that's how we're going to approach this crisis. And, people who use drugs have been calling for safe supply forever. And so, yeah, and it doesn't, like, the medical model is not what that call was about. So yeah, it's but yeah, I really appreciate your paper because it does, and your research, because it does help us articulate these arguments, and your framework it was great to use. Yeah. See why you chose
Maybe
that.
I'll just add to Rebecca to that. It's like it is interesting that it did emerge from this work that is opportunity for allyship for the prescriber community, who traditionally hold a lot of power and are listened to as stakeholders, to ally with what people with lived experience have been saying for so long around what safe supply should really look like. And so just to re-emphasize that did emerge from this research, that there is that opportunity for allyship with the prescriber communities to support that same messaging around the need for real policy changes, regulatory or legal changes, to truly scale this in a way that can make a big difference overall.
Yeah, and as an implementation scientist who studies the implementation of these things and what works and doesn't work, that you look at this and you might think, well, maybe the best thing is just to tear it all down and start over, but you can't do that because people need to continue to access the services that they have and know. And that it's such a big task, you could put your hands up and say, oh, we're never going to get here. No, you need to address things and you do the low-hanging fruit first, because that's what's most feasible. And then as more people join the forces, the messaging becomes louder, and you know, certain folks in decision-making positions have been receptive to research like ours and other research that's going on. And so, you know, we're seeing some shifts in policy that are happening. There's some funding, for example, the funding that you received to build this community of practice, which is really promising. And so, you know, it's sustaining things like this and then looking at what's the next priority. We have to prioritize these barriers and tackle them where we can and keep working to build what needs to happen. So, and not reinventing the wheel by connecting around what works operationally, from an implementation perspective, from an evaluation perspective, all these things. The more collective we are, I think the more we'll be able to share that learning and make the changes more efficient than they would be if we were all working in silos.
Again, well said. Thank you, Stephanie. Any other questions? All right, then. As we said, we will be posting this webinar up on our website, so you'll be able to find that there within the next couple of days. And we'll also post links to the paper that Stephanie and Nadia have been talking about, and the other paper as well. Stephanie will include both papers on the website with this video, so it's there. And I think your contact information is also on there, or you can reach out to us, and we'll connect you to Stephanie and Nadia as well. Thank you both so much for being here today. I really, really appreciate it. And not only does the paper have a great title that catches your eye, but it's got some really valuable information that I think lots of people on this call and obviously much wider will be using to help support their funding applications and their research and their work as well. So, and that's the whole thing, right? Is when the research goes and informs practice. So thank you for that.
Yeah, thank you for having us. We really appreciate the opportunity to share the findings with this group. Thanks everyone for joining and sharing your time with us today. As we publish the other articles which will focus on these barriers and facilitators and the strategies, we'll definitely pass them along so that they can go up as well and be shared with the community. And if you have questions that come to you later, yeah, feel free to reach out to us. But thank you again for having us.
Thank you. And we'll have you back when those other papers are ready to be talked about and such. Thank you. And I'll echo Stephanie's thanks to all of our attendees here today, everyone in the audience. Thanks for being here, taking the time to be with us today. And we hope to see you again in January. All right. Thanks, everyone. Bye-bye.